Hello everyone. In this presentation, I will review some fundamentals of the MRI epilepsy protocol, as well as the visual evaluation of prevalent lesions causing drug-resistant epilepsy. So first, I would like to underline the importance of performing high-quality MRI. We recently proposed the harmonized neuroimaging of epilepsy structural sequences, or harness MRI protocol, which we think is crucial for an optimal visual evaluation. This protocol consists of 3 core high-resolution sequences, 3D T1 and 3D FLAIR isotropic images with millimetric resolution, and 2D submillimetric T2-weighted MRI. So now, why should you perform the harness protocol? Well, this is for several reasons. First, it provides high contrast, high resolution sequences. It's actually relatively easy to implement and is optimized for 3 Tesla scanners, but is feasible on 1.5 Tesla systems. The caveat here is that the image quality will be obligatory slightly inferior. Best results are obtained when using multiple phased array coils, which on one hand improve signal to noise and tissue contrast, but they also allow the use of image acceleration or parallel imaging, such as GRAPPA, ASSET, or SENSE. In addition, these sequences provide whole brain coverage. They reduce partial volume effects and may be reformatted in any plane without loss of resolution. Now, the harness protocol is applicable both to adults and children, and in fact is quite time effective because you can do the whole protocol in 30 minutes, which means approximately 6 minutes per scan, when using the multiple phase array coils I just mentioned above. Now, when a tumor, a vascular malformation, or an infectious process is suspected, additional contrast is needed, such as gadolinium MRI to rule out enhancements, or susceptibility-weighted T2 star images to check for blood, iron deposits, or calcifications. Now, who may benefit from the harness protocol? In fact, we believe that every patient soon after the first seizures, if resources allow, should have an harness MRI protocol to establish syndromic definition and guide clinical management. And this is because the MRI is highly sensitive and specific, because there is a high rate of seizure recurrence in patients with MRI lesions, and because the identification of a lesion should be an incentive to, on one hand, strictly adhere to clinical criteria for drug resistance, and on the other, if drug resistance is confirmed, the patients should refer to an epilepsy surgery center for further evaluation. And this is particularly important in children, as ongoing myelination may mask focal cortical dysplasia on later MRI. Now, recommending the harness protocol there is insufficient evidence to recommend the harness protocol in genetic generalized epilepsy and self-limited drug-responsive epilepsy syndromes, with the exception if you face a developmental delay, cognitive decline, or new onset of drug resistance or focal epileptic spikes. So now, what are the situations in which the harness protocol should be repeated? Well, there are basically 3 situations. The first one is when the previous MRI is not available, suboptimal, or it was read by somebody with insufficient experience. So relying on previous written radiological reports is never a good idea, is actually insufficient. You should look at the images yourself if you can. And secondly, optimized imaging reveals a lesion in more than 60% of patients of so-called normal MRI cases. Also, the harness protocol should be repeated in young children. With the MRI in the first region, in fact, in the first year, may in fact identify focal cortical dysplasia manifesting with only subtle changes later on in life in the post-myelinated brain. And you should in fact retain this early MRI exam for comparison with later repeated imaging. And finally, the harness MRI protocol should be repeated when you have an unexpected seizure frequency increase, onset or worsening of neuropsychiatric symptoms, and rapid cognitive decline. So here are the details regarding the harness protocol, which consists of 3 core sequences. The first one is a T1-weighted 3D sequence. Generic name for this sequence is a gradient echo, or GRE sequence. Importantly, this sequence has a voxel size of 1 by 1 by 1 millimeter. So the size of the voxel is equal in each plane. And there are no interslice gaps. That is very important. And this sequence is best to evaluate brain morphology, such as volume, thickness, sulcogyral shape, as well as gray-white matter interface changes. And on Siemens scanners, the typical sequence is an MP-RAGE sequence. The second core sequence is a 3D flare. The generic name is a turbospin echo, or TSE. The voxel size, again, is a isotropic 1 by 1 by 1 millimeter with no interslice gap. And this sequence is best to evaluate signal intensities related to gliosis or focal cortical dysplasias. Now, the last sequence is a 2D sequence, a T2-weighted two-dimensional sequence, or a TSE turbospin echo. The voxel size is 0.4 by 0.4 by 2 millimeters, and there are, again, no interslice gaps. And this sequence is best for the evaluation of the hippocampus, particularly the internal structure of the hippocampus. The caveat here is that this sequence is prone to artifacts related to movement, flow, and susceptibility. Now, I've mentioned before the importance of performing high-quality MRI. This applies particularly to drug-resistant epilepsy, which is often associated with a structural lesion. The most prevalent lesions are hippocampal sclerosis related to temporal lobe epilepsy and cortical malformations related to extratemporal epilepsy. Importantly, the surgical removal of the structural lesion is the only effective treatment to control seizures. So let's start with temporal lobe epilepsy. First of all, when examining patients with suspected TLE, it is essential to know in detail the anatomy of the temporal lobe. Here, you can see coronal sections across the temporal lobe. In the most anterior portion of the temporal lobe, or section 1, you can see the amygdala and the first appearance of the hippocampal head. We can also appreciate the various components of the parahippocampal gyrus, including the entorhinal cortex and the perianal cortex separated by the collateral sulcus. At the level of the hippocampal head, you can appreciate these bumps called hippocampal digitations, covered by the alveus, which contains axonal fibers formed from the dentate gyrus and the CA subfields. At this midsection, we are at the level of the hippocampal body covered by the fimbria. At this level, the subiculum is nicely visible. Finally, at the level of the hippocampal tail, you can see the merging of the fimbria into the fornix. Now, from the pathological perspective, TLE is not focal. Indeed, besides the hippocampus, neuronal loss and gliosis is present in the entorhinal cortex, the amygdala, and the neocortex. Patterns of hippocampal sclerosis are also diverse and may affect diffusely all subfields, predominantly CA1 or predominantly CA4. Also, a large proportion of patients may only display isolated gliosis. These pathological distinctions impact the visibility of HS on MRI. In general, patients with diffuse or predominant CA1 neuronal loss are MRI positive, while those with neuronal loss in CA4 or gliosis are difficult to see on MRI. On MRI, the main features of hippocampal sclerosis are hippocampal atrophy associated with neuronal loss, altered signal indicative of gliosis, and increased extracellular space, and loss of internal structure is another important feature. At the level of the head, we look for loss of digitations, as you can appreciate here, comparing the right sclerotic hippocampus to the healthy left hippocampus, where digitations are clearly visible. We also see T2 hyperintensity, often associated with T1 hypointensity, and a loss of internal structure. At the level of the body, atrophy is associated with the flattening of the hippocampus. And again, as shown here, we can see T2 hyperintensity and T1 hypointensity. More posteriorly, at the level of the tail, beside hippocampal atrophy, a useful sign is atrophy of the fornix, as you can appreciate in this example. Another feature you should always look for is temporal pole atrophy and increased T2 signal, which are best seen on FLAIR images as in this example. You can see that the gray matter, white matter boundary of the right temporal pole is blurred and is hyper-intense compared to the left. Oftentimes, when examining the MRI, one is attracted by the asymmetry of the horns of the lateral ventricles. However, be aware, this may be an invalid sign. In fact, very often it gives a false lateralization, as shown in this example of left TLE, in whom the lateral horn is enlarged on the right side. The signs I just showed you are typical in patients with severe hippocampal sclerosis, as in this example. However, as I mentioned before, there is an MRI spectrum of hippocampal sclerosis. Indeed, in many cases, the histopathological anomalies are subtle and difficult to detect visually on MRI. These patients are referred to as MRI negative. In this TLE case, the left hippocampus does not look atrophic on T1 weighted MRI, but there is a subtle increase in T2 signal and loss of internal structure that is better appreciated on this magnified image. In fact, when carefully comparing the left to the right, the molecular layer, this black band, which separates the CA subfields from the dentate gyrus, becomes blurred. These type of features are those you need to train your eyes to see if you don't want to miss subtle forms of hippocampal sclerosis. In addition to hippocampal sclerosis, there are two often under-recognized mesotemporal lobe anomalies associated with temporal lobe epilepsy. The first is parahippocampal dysplasia. In these cases, the MRI is often reported as negative. Yet, you can see here a blurring of the parahippocampal white matter, particularly on T1 weighted images. It is important to recognize these lesions since the electroclinical picture may be misleading, as in this patient who was first operated unsuccessfully in the lower frontal convexity and in whom a right parahippocampal dysplasia was found after a right temporal lobe resection. The second under-recognized etiology of so-called MRI negative TLE are encephaloceles, which are protrusions of brain tissue through small skull base defects. These anomalies may be unilateral or bilateral. Here you have other examples in which you can see the protrusion as well as the skull defect on the bone windows of this CT scan. Interestingly, the histopathology of these lesions is suggestive of a cortical malformation, as in this example. Now, hippocampal malrotation is an anomaly often misdiagnosed as hippocampal sclerosis. This is understandable, as this malformation can be associated with HS. However, in many cases, hippocampal malrotation is an independent entity. Compared to a normally positioned hippocampus, the malrotated hippocampus is vertically oriented and medially positioned with respect to the midline, and oftentimes associated with a deep collateral sulcus. Interestingly, there is a striking similarity between these features and the fetal healthy hippocampus at 19th gestational week and the hippocampus of a lissencephalic brain, an extreme type of malformation of cortical development in which there is almost no gyration. This led us to think that hippocampal malrotation in adults may be secondary to an incomplete inversion of the fetal hippocampus and its adjacent structures, and thus be a marker of an abnormal brain development. Here you can see again the features of malrotation that we quantified compared to healthy controls. Medial positioning means that the center of the hippocampus gets closer to the midline. The vertical orientation is characterized by an abnormal change in the axis of the hippocampus, as shown here. Also, the malrotated hippocampus is typically rounder than the healthy hippocampus. Finally, the collateral sulcus is deeper. Hippocampal malrotation is present in less than 10% of healthy control, but is prevalent in both TLE and in patients with malformations of cortical development. Importantly, malrotation is more frequently seen on the left hemisphere. Also, in all studies done so far, there is no association with the site of seizure focus or hippocampal atrophy. I will now review the MRI features of prevalent cortical malformations. Let's start with some essential concepts on these epileptogenic malformations. Overall, they are subdivided with respect to the timetable of key neurodevelopmental stages. FCD type 2 is an early malformation caused by abnormal neuroglial proliferation linked to atypical expression of genes controlling mitotic cycles and cell growth. Another group includes malformation related to abnormal neuronal migration due to dysfunction of the neuroepithelial integrity impairing migratory initiation and cell adhesion. Typical examples are heterotopias, characterized by gray matter nodules located at the various steps in the white matter. The third group is due to postmigratory defects of cortical organization resulting in polymicrogyrus, characterized by an excessive number of shallow gyri and sulci. Focal cortical dysplasia is the most prevalent surgically amenable malformation. Compared to the well-organized 6-layer neocortex, the histopathological signature of FCD type 2 associate altered laminar organization and cytological abnormalities. Dysmorphic neurons characterize FCD type 2A, while the typical feature of FCD type 2B are eosinophilic enlarged balloon cells. Gliosis and activated glia are also variable features of FCD, together with hypomyelination. The anomalies may extend from the superficial cortical layer 1 to the subcortical white matter, thereby causing variable degrees of cortical thickening, blurring of the gray-white matter transition, In many cases, FCD can be seen on MRI. In fact, both FCD type 2B and type 2A generally present with increased cortical thickness, blurring of the gray-white matter transition, and intensity changes best seen on FLAIR as shown in these two examples. However, the MRI spectrum of FCD comprised variable degrees of gray matter and white matter changes, making the visual detection challenging in many cases, particularly when inspecting the convoluted cortex on 2D images, as in these two examples, in whom blurring of the gray-white matter transition may be very, very subtle. These cases are typically referred to as MRI negative. Importantly, however, these cases are not negative. On the contrary, the lesion is there, but very difficult to see. Here is another example of a case of a so-called MRI negative frontal lobe epilepsy, in whom you can see this very subtle transmantle sign shown by the arrows as a fingerprint of the abnormal neuronal migration within the white matter. Note that this sign is almost exclusively seen on FLAIR images. This is another case. Again, the transmantle sign may be the only sign that can be seen together with this very subtle blurring at the bottom of a sulcus. And this is the small surgical resection that made the patient seizure-free. I want to conclude this section with a caveat regarding the manipulation of images. In fact, as I said before, one of the advantages of 3D images is to reduce partial volume effects. Unfortunately, sometimes radiologists often choose to reconstruct 3D images into thicker 2D slabs, at times with the addition of interslice gaps. This is not a good idea, as subtle anomalies may be missed. In this example, the 3D FLAIR images were reconstructed at 3 mm thickness, and the lesion was missed, and the case was reported as negative. However, when inspecting the original 1 mm resolution, you can see both of the blurring of the gray and white matter and the subtle transmantle sign of the small FCD lesion. Unfortunately, this information was lost when reformatted images at a lower resolution, making, in fact, the visible invisible. The second group of epileptogenic malformations includes those related to a failure of neuronal migration due to dysfunction of neuroepithelial integrity, impairing migratory initiation and cell adhesion. Typical examples are heterotopias characterized by ectopic gray matter located at various depths within the white matter. Lissencephaly syndromes are characterized by a spectrum. The most severe forms include agyra, typified by absent brain convolutions, and pachygyra with decreased or thick brain folds. And at the end of the spectrum, the middle form is subcortical band heterotopia or double cortex, characterized by an ectopic band of gray matter located below the normotopic neocortex. To date, mutation of 6 genes that regulate neuroblasts' conversion to migratory cells have been associated with lissencephaly. Mutation in either LIS1 or double cortin account for approximately 80% of cases. Others account for a small percentage, leaving 10 to 20% of patients without a genetic diagnosis. Importantly, LIS syndromes are heterogeneous, both from the imaging and genetic point of view. In general, however, LIS1 mutations due to large deletions lead to severe posterior MRI anomalies, while double cortin mutations lead to mild anterior changes. Here is an example of double cortex. You can appreciate how different the visibility of the band is, both with respect to anatomical location, here at the top, and MRI cuts, underline the importance of performing 3D imaging. Here is an example again of double cortex, where you can see on a curvilinear reformatting the malformation in the posterior quadrant, but you can see also associated package area in the anterior portion of the frontal lobe. So the double cortex malformation is at times difficult to see and associated with package area. This is another view of the same case. Again, you can see the double cortex in the back here, and then the package area up in the front. Now, periventricular nodular heterotopias are characterized by ectopic gray matter around the ventricles due to mutation of filamin A, a protein responsible for cell motility and adhesion. Subcortical heterotopias, on the other hand, are collections within the white matter. Interestingly, electrophysiological and imaging observation have shown that the neocortex overlying the nodule is abnormal, suggesting the presence of a more diffuse brain structural and functional anomaly. And here is another example of periventricular nodular heterotopia, shown by the yellow arrows here. And this is an example of a subcortical nodular heterotopia. Now, the third group of malformations is associated with postmigratory disturbances of cortical organization resulting in polymicrogyras, characterized by an excessive number of shallow gyri and sulci. The most common forms are bilateral polymicrogyras. Bilateral perisylvian polymicrogyra are linked to mutations of the sushi repeat containing protein X linked to SRPX2 gene, while bilateral frontal forms are associated with mutation of the G protein coupled receptor gene, or GPR56, which regulates regional cortical patterns. Here is a patient with bilateral occipital polymicrogyra showing an excessive number of shallow gyri and sulci in both occipital cortices, which is best seen in this magnified coronal view. In this curvilinear formatting, you can see how the polymicrogyra dramatically modifies the gyral pattern in the occipital regions, with an abnormal parallel arrangement of the gyri affected by the malformation. And these are different views of the malformation and this parallel vortex-like organized gyrification in the posterior quadrants. Polymicrogyras can be also unilateral. Their genetic underpinning remains unclear, but possibly related to abnormalities of the transcription factor LMO4, which in preclinical models defines the shape of functional areas in the developing cortices and regulates sensory motor control. As shown by these examples, unilateral polymicrogyra may affect specific anatomical regions or the entire hemisphere, shown here. So to conclude, practices on the use of structural MRI are clearly variable worldwide and may not harness the technological advances for the benefit of people with epilepsy. In response to this situation, we have suggested the harness protocol, which standardized best practice neuroimaging of epilepsy in outpatient clinics and specialized surgery centers alike. Epileptologists should in fact be trained, we believe, to recognize the full spectrum of epileptogenic lesions in order to minimize the number of so-called MRI negative cases. And lastly, the identification of a structural lesion in recent onset epilepsy is an indicator of drug resistance and an incentive to refer the patient to a center specialized in epilepsy surgery. And with this, I conclude and thank you for your attention.